So thank you for joining us for this month's meeting of the CTeL Telehealth Working Group. The main thing that I wanted to discuss today was the recent government shutdown, or at least partial shutdown, alongside the brief expiration of Medicare telehealth reimbursement waivers. In the legislation that reauthorized those waivers, there were some new provisions included as well that I wanted to go over for our awareness, and then talk a little bit about the ASTP annual meeting starting tomorrow, and then any other items that we wanted to discuss. And so, as you may have seen, on January 30th, the federal government entered a partial government shutdown when funding for a handful of agencies expired without a new bill to fund them through the rest of the year. And alongside of that was an expiration of Medicare telehealth waivers, which were also set to expire on the same day in the same deal that funded those agencies. And so over the weekend, the House and Senate worked to pass a new funding bill that could make it through both chambers and be signed by the president, which ultimately happened on February 3rd, with the Consolidated Appropriations Act of 2026 being signed into law. Notably, in this funding bill was an extension of Medicare telehealth reimbursement flexibilities, things like eliminating geographic and originating site restrictions, expanding provider types, and so on. These were extended through December 31st, 2027. And so this is a pretty big extension of these waivers, much longer than previous extensions. However, these is not a permanent extension, and unless things change, we'll be back at the same place just in about a year and so. I also wanted to note that the Acute Hospital Care at Home program was also extended in this bill through September 30th, 2030. And so that's a 5-year extension and a 2-year extension of the Medicare telehealth reimbursement flexibilities. In reflecting these changes, CMS has updated its 2026 telehealth FAQ document, which notes that telehealth flexibilities will apply retroactively as if there were not a shutdown. So even though the shutdown was only a few days, if you provided telehealth services during that period and submitted for reimbursement, these flexibilities would apply retroactively. Any questions on the brief shutdown and waiver lapse? I also wanted to note that in this bill, it wasn't just an extension of the telehealth waivers, but there was also some new policies that were included, um, specifically that it is requiring HHS to create new modifiers for telehealth services furnished through a quote telehealth virtual platform by a practitioner that contracts with an entity that owns such a platform, or for which a practitioner has a payment arrangement with an entity for use of such virtual platform, as well as claims for telehealth services furnished incident to a physician's or practitioner's professional service. The bill hasn't gone into much more specifics in the actual legal language itself, other than this. This is a direct paste from the bill as was signed into law. However, on the next slide, we'll talk a little bit more about some of the background of these provisions and why we might be seeing them come in now. There is also included in the bill language for HHS to provide materials for furnishing telehealth services for limited English proficiency patients as well. Any questions on these provisions? I will also note that the bill did include some new restrictions on the hospice recertification um, provision as well, and that there are specific instances. where hospice programs may not be eligible for telehealth recertification that were included in the bill as well. Um, and so this is not just an extension of the telehealth ex waivers, but there are new policies that are coming through as well as Congress continues to look towards a pathway to permanency. And so talking a little bit about why these new modifiers are being added now, we did some research on this, and there was a policy paper put out by the Bipartisan Policy Center back in July of 2024, which recommended fully eliminating Incident to billing. However, it recommended as a first step, at least creating a new modifier code to at least track the prevalence of Incident to billing in telehealth, as well as makes a similar recommendation for fully virtual providers in Medicare, and creating new modifiers to track the prevalence of that as well. And so the goal of these new modifiers that the bill is requiring HHS to create is likely to get more data on the prevalence of certain practices that may be believed to lead to certain fraudulent billing practices. Any questions here?
Yeah, Lydia Joe, what's an example or two of that? Examples of alleged or feared fraudulent behavior under the incident to banner in telehealth.
Yeah, the report goes into the screenshot is just an excerpt of the report, and I can find the full report, which talks a little bit more about this. But it's kind of coming from the same place as with the virtual providers, is that it's just used as a way to not necessarily upcode, but they feel that it's might be an indicator of certain fraudulent activities. Pulling up the report right now, I put a um, link to it in the chat. Um, and I can go to that section right now, just so I can see kind of how they're justifying this provision. So yeah, it's saying to help policymakers understand who is delivering video and audio only visits and in what quantity. CMS should prohibit incident to billing by any provider who can bill Medicare directly. Before COVID, incident to billing enabled non-physician providers, such as nurse practitioners or physician assistants, to bill under a supervising physician's higher rate, provided the physician was virtually present in the same office. Since COVID, CMS has allowed for virtual supervision, in which the physician is available online as needed. MedPAC has raised concerns about incident to billing for telehealth and more broadly, noting that it makes it harder to monitor the quality of services. Ending this practice will support research into quality of care as well as efforts to detect and investigate fraud.
Hmm. Thank you. Is that based on any actual observed problem, or is it more a theoretical possibility that MedPAC is worried about?
Let's see what I'm wondering if this cites any specific incidents or data on this.
Well, I don't mean to derail the whole train. I was just
Mhm.
curious if this is real or it's more hypothetical.
Yeah, I'm not sure if this has any specific data that's being cited um, aside from some of the payment data. Um, Part of it might be that they're citing that there is little up-to-date information regarding this, and so it looks like that by creating a new modifier, um, they want to have a better understanding of the prevalence of this and determine whether or not it's something worth addressing more thoroughly.
Okay.
And I'll put the link to this report in the chat in case anyone is interested in looking at it as well. Any other questions here? Lastly, for anyone who's either working out of DC or coming to DC tomorrow and Thursday, the Assistant Secretary for Technology Policy Office of HHS is hosting its annual meeting, which is free and open to the public. CTeL and a handful of members will be there. This is tomorrow and Thursday in DC. They've published the agenda, which part of which will be um, streaming available for streaming online. You can also register on their website if you're interested in attending. Um, but a lot of it will be surrounding some of HHS's health IT activities, such as its information session on its recently published US CDI version 7, a listening session for its diagnostic imaging RFI that it published, a two two session boot camp on information blocking, a listening session on prior authorization, as well as some panels on artificial intelligence and some of HHS's other health IT priorities. So if anyone is either attending or interested in attending, I'll be there if you want to say hi. I've been to this conference past few years, and there's always a lot of interesting presentations, especially in the areas of health IT and digital health. So I definitely recommend going if you're in DC and able to make it. Any questions here? And of course, any items that we did not discuss today or any questions you have outside of our discussion items.
Lydia Joe again. I don't know how many times we have seen extensions of the various pandemic-related flexibilities, but there've been a lot of them.
Hmm.
It's gone on now for years. The original concern that the flexibilities address arose from congressional anxiety that the telehealth world would go crazy and bill and bill and bill and bill and drive the national debt even higher than it already is. Um, would it make sense for the CTELs of the world to prepare some kind of analysis of these extensions from their inception to the present, perhaps, to see whether there's anything to the underlying congressional anxiety that gave rise to 1834M and its restrictions in the first place? And if not, then to use that as a basis to argue that, look, instead of doing this, well, this banana republic approach where every 6 months or every 12 months we do a mother may I and we grant permission to proceed, just make a decision already. And based on the data available, at least I'm assuming this will be true, I may be wrong. Based on the data available, the original concern, however logical, is unjustified and it's time to put an end to this.
Yeah, this is it's kind of in the question that's been hovering over this telehealth issue for a while. And it's what drove our initial cost impact study that we published a few years ago. Um, Interestingly, in the CBO, when it scored this bill, it gave also a score for the telehealth extension.
Hmm.
Um, I'm wondering if I can um, find that specific um, portion, but it basically says that the for a uh, this extension through um, 2028 or at least for the year of 2027 that it would be about $2.126 billion, which is
In
actually
additional expense?
yes,
Okay.
which is actually on kind of the higher end in terms of CBO scores of telehealth extensions. Um, and part of that, if you are at the Spring Digital Health Summit we held last year, we actually had an analyst from the CBO come and talk about kind of what the office has been thinking through when it's scoring telehealth for Medicare. And part of the issue is that there's not believed to be enough clinical evidence to justify including many of the cost-saving factors that CTeL and others identify, um, in including those in their actual scoring tabulations. Um, and so we're seeing a resistance to actually incorporate some of CTeL's findings and other researchers' findings about telehealth cost savings because CBO isn't convinced yet that there's a good enough link between those two. And so we're still seeing pretty high telehealth scores. And so for the time being, Congress is invested in these short-term extensions because they don't want to see them expire, but they also don't want to see it be permanent because they feel that either direction would have certain political drawbacks for them. And so right now we're stuck in this kind of endless extensions. We're
I'm
continuing our
kind of,
talk. Oh,
I'm
sorry.
sorry. I'm kind of looking at it from the other direction, or maybe in a lawyer's terms, I'm asking that the burden of proof be shifted. This is a projection, is it not, of what CBO guesses will be the additional cost to Uncle Sam to extend these things through 2028 or whatever it is. Have they not made similar predictions about the cost of such flexibilities during multiple reiterations of the same concept since COVID started? Now, you may know, but I do not. What's been their batting average? They predicted that the cost would be X, more than would have been the case otherwise. Well, how much more was it, if anything? Maybe they're exactly right. Maybe their predictions have been right on the money. Well, good for them. But if not, would it not be a fair question to say, look, you guys keep predicting this. It doesn't happen. You're predicting it again. Odds are it won't happen. Enough already. There isn't a logical basis for the obstructionism that you've engaged in since day one. So stop with the whining and just accept that no, in fact, the cost will not be what you project. If anything, it might be. I don't know what the numbers are. I may not be able to make that argument. Maybe the data do not justify it. I'm just asking, let's look at the data. If there's a way to do this, see what their batting average has been. If if they're a 300 hitter, well, good for them. But if not, maybe it's time to say, look, your projections just don't seem to fit reality. And this is not a legitimate concern.
Yeah, we have seen that at least in the past. CBO has had a bit of an overestimate of cost impact. Um, Part of the issue with some of these numbers is that it's hard to take into account. For example, a lot of the cost savings is in avoidable hospital visits, for example.
Hmm.
And so while Medicare may spend X amount of dollars on the telehealth visit, the hospital visit that later saved isn't calculated. All that Medicare knows is that it spent that X amount of dollars on that telehealth visit, and then that goes into the broader calculation of spending. And so finding a way for at least the economic analysis of telehealth's cost impact. Um, Part of the problem is finding a way to incorporate a lot of those kinds of cost savings into these final numbers.
But I'm suggesting instead of focusing upon whether we save money or not, focus on the flip side of that question. Are we squandering money or not? If the CBO projects that because of the flexibilities, the cost of the program will be so many dollars higher than it would be otherwise, and they make that projection over and over again, and indeed costs can be legitimately attributed to these flexibilities in a fashion that's reasonably close to their estimates, well, good for them. I will sit down and shut up. But if, on the contrary, the extra cost that CBO projects is not realized, and that failure of realization occurs not once, not twice, but repeatedly, then maybe it's time not to ask the CTELs to say, hey, where's your evidence you save money, but rather to ask the CBO, where's your evidence we're spending money needlessly, spending money fruitlessly?
Yeah, for sure. And I think part of the issue also is that oftentimes CBO doesn't show the specific math or calculations that it's making, at least publicly, when it comes to these numbers. So we don't really know how they're coming to these numbers, just that they have this $2.126 billion number. And Congress tends to defer to CBO um, quite a lot. Um, and so we also don't really know how they're actually coming to these numbers as well.
Okay, I understand that. It would be nice if we did, but still, they have made projections.
Hmm.
Regardless of how they came to these conclusions, they have publicly expressed the view that the flexibilities increase costs by stated sums. Why would it not be possible to go back and look at the track record and see whether indeed that has happened or not? Is that, does the methodology preclude our doing such an analysis?
I wouldn't think so, no.
Well, if if they're close, obviously not to the penny, but they're close, then okay, then I guess it is a fair question to ask CTEL, well, where's the evidence that we save money or at least don't increase costs? But if they're not particularly close, especially if they're off by a significant margin repeatedly, I seems to me a perfectly legitimate question to turn things around and say, rather than asking CTEL, where's the evidence of savings, ask CBO, where's the evidence of this extra cost that you keep projecting? The data do not seem to bear out your projections. So perhaps you should reconsider how you do them.
Right, for sure. And I would agree with that.
Okay, end of sermon. I'll get off your back.
So is the ask that you're looking for us to um, compare the CBO estimates of telehealth flexibility extensions with some of the claims data that we have and determine how close they are together.
Candidly, I'm not sure I'm competent to answer the question. I guess I would rephrase it to say, if it can be done with only reasonable and not unreasonable effort, and if the data allow the analysis, compare the CBO's projections over the last however many flexibility extensions there have been with actual data on cost and determine whether CBO's projections have been reasonably accurate or not. Now, I'm not enough of an economist or a health data cruncher number, uh, data cruncher to be able to articulate how you would do that. Maybe the EILs and Jasons of the world can either tell me that's not feasible or tell me how to do it. But I clearly not the right person to ask. I took 2 years of college math and survived, but I can't say anything beyond that. And that was a long time ago.
For sure. And that's definitely something that we can look into as well.
Okay, thanks.
Any other questions or discussion items? If not, then later this month, registration is open for our clinical workforce shortage roundtable discussion, which will be held virtually, and examine the role that digital health plays in expanding the pipeline for entry into the health workforce, promoting retention and ensuring that workers have a safe and supportive environment, and preventing clinician burnout and reducing administrative burden. Registration is available online through the CTeL website on our events calendar. Thank you so much for joining for this month's meeting of our working group. If you have any questions, I'm always available via email. I hope you have a great rest of your day.